So it's important that you understand how decision making happens in clinical care. And important in understanding that are the concepts of sensitivity and specificity. So let's look at those things and figure out what they are. First of all, what is it that makes a good diagnostic test? Well, there are several things. The first thing is it has to be necessary. We don't go around testing everybody for Huntington's chorea because it makes no sense, right? We have specific people who are at risk who want to be tested, and that's who we test. The test also needs to be safe. We don't submit people for crazy testing that puts people at risk. Not everybody gets an exploratory lap to explore their abdominal pain because it's not a completely safe procedure. It's safe in the right circumstances, of course. The test needs to be accurate. That is, and we have very specific definitions of these things, but the word accurate means that it makes the correct diagnosis. Okay? That's the definition of accurate when we're talking about diagnostic testing. The test also needs to be reliable. Every time we do the test, it needs to give the same result. The test needs to be valid. If we do a test for a hemoglobin, we have to make sure that it tests the hemoglobin, not the platelet count, for instance. Okay? So it sounds silly, but it's really a very important component. Now, the test also needs to be sensitive or specific, depending on which we're interested in. Ideally, the perfect test would have 100% sensitivity and 100% specificity, and we'd be done. But that's just not how it works. So let's define the terms. Sensitive tests are tests that include all the people with the disease. So anybody who has the disease who gets this test will be positive. Specific tests exclude patients who don't have the disease. Now let's look a little bit more deeply at sensitivity and specificity. Sensitive tests ask a particular question, and that particular question is, among patients with the disease, which patients will have an abnormal test? It's kind of a weird question, right? Among patients who have the disease, which will have an abnormal test? Well, that's kind of weird because that's why we're doing the test, to see if they have the disease. But this is really important to understand because this measure, sensitivity, is a measure of the test itself. We're trying to understand how good is this test for telling us if somebody has the disease. Does that make sense? So it asks the question, among patients with the disease, which ones will have an abnormal test? That means that when we apply this test, if it's highly sensitive, it's going to include all the patients who have the disease. But maybe there will be some patients who test positive who don't have the disease, right? All right, so let's look now at specificity. Specificity is the opposite. It asks the question, among patients without the disease, which will have a normal test? Among patients without the disease, which ones will have a normal test? That means that we're excluding all the patients who do not have the disease. But there may be some people who test negative who actually have the disease. Those are false negatives. So let's put this into practice. Let's take a test like stress testing. So exercise stress testing, been around for 70, 80 years. And we can put patients on a treadmill and walk them for a period of time. And we're trying to determine how many of those patients have CAD, right? Coronary artery disease. So we do an experiment. We take people who we know have the disease, and we put 100 people on a treadmill who have the disease and 100 people who do not have the disease. All right. And then we do we do a stress test, and then people will either test negative or test positive. Well, when we plot those on this table, we can do some math then, right? So the people who tested normal totaled 90 patients out of those 200 that we did the test on. And then 110 were abnormal. So now we can do some math to figure out the sensitivity and specificity. The sensitivity is the number of true positives divided by the true positives plus the false negatives. Okay? Specificity then is a little different. It's the true negatives divided by true negatives plus false positives. And when we put it into the machine and turn the crank, we find out that this stress testing had a sensitivity of 90%. Pretty good, right? 90% of the time, when we ask the question among patients who have the disease, which will test positive, we have the test is 90% sensitive. Does that make sense? So why are we talking about all that? Well, it's important that we know when not to apply a test. So in cancer, for instance, we can do tests that reveal tumor markers. But when do we apply those tests? Is it a good idea to do a CEA for colorectal cancer to screen for colorectal cancer? Well, let's look at the numbers. This is the CEA test for colorectal cancer, and we see that early in the disease, it only has a 25% sensitivity. Late in the disease, it has a 75% sensitivity. That's pretty good, but not great. So with that in mind, does it seem like doing a CEA is a good test to screen for colon cancer? No, and that's why we don't do it. We have other tests that have higher sensitivity and specificity for colon cancer. And, the predominant one, of course, is colorectal screening with colonoscopy.